So I hope that provides at least a framework for all of us around the definition of what palliative care is. And we'll move now to a clinical case of a patient with major depression in the context of a cancer diagnosis. So Miss A is a 38-year-old female who presented to my clinic. She has a stage 4 glioblastoma and is on active treatment with chemotherapy for this brain tumor. And she was referred due to a complaint primarily of feeling down and depressed. And when she presented, she was having significant amounts of pain, kind of primarily all over her body, but was primarily feeling terribly sad every day, most of the time. Her symptoms included significant weight loss, about 20 pounds over the preceding 6 weeks, was having significant insomnia due to pain from headaches associated with her tumor. She was feeling very guilty about her disease progressing, particularly was feeling guilty that she had to leave working and was due to loss of concentration and focus at work. She began to lose interest in caring for her children because she didn't see any reason to keep doing that because she was, quote unquote, dying anyway, and was very tearful and hopeless throughout the visit. Her family was very distressed by the amount of hopelessness and helplessness she was experiencing in the context of her treatment. This young lady had no prior mental health history. She had some mild depressive symptoms after the birth of her second child, some postpartum symptoms. She had been prescribed a medication by her primary physician, her generalist, that caused some gastroenterologic side effects, and so she had stopped taking it and had really had no prior medication trials. She had a significant family history. Her mom had had probably a mood disorder like depression, though had received some talk therapy, never took any medicines. And most importantly, she had a maternal uncle who had a completed suicide. And when I assess patients for mental health issues, because the high genetic corollary for primary relatives, the family history is really important in taking a psychiatric history. And if you have a primary relative with a mood disorder or completed suicide, that's high risk for your patient. And so one of the fun things about doing mental health is that the family history is really, really important. So I recognize that in the context of Mrs. A's case is that she's got brain cancer. And so she has a big tumor in her brain, which is probably contributing to some of her mood symptoms. Yet we sort of forget that patients that have cancer, even if it's a really bad cancer, can have significant mood symptomatology that would actually benefit from symptom management to help their quality of life. And it can be hard in this patient population, and I kind of highlight this patient with a brain tumor to say, how do we figure out if all of these mood symptoms are just pain, if it's just for cancer, or is this really a symptom of major depression, a disorder that is causing dysfunction, and how do we best address that to improve her quality of life? And are there tools that we can use to make diagnosing that in the context of having something like cancer easier so we can come up with a therapeutic intervention? And I really like bedside tools that help us to not have to think too hard, to be able to make a diagnosis quickly and then help to come up with an intervention.